Hi, good evening, everyone. Today I'll be presenting the Cold Blue for the month of March. I know I'm a little bit late than usual because the coronavirus, and we are adapting by doing this video presentation in order to maintain social distance. Um, Today we're going to be talking about adrenal crisis, and our title, "I Need More Stress," is tells us exactly what's going on in this particular disease. We don't have enough stress hormones. So next slide, we'll be looking at our course objectives, the definition. We're also going to be talking a little bit about the pertinent anatomy in order to kind of get a better understanding of mechanism of action um, and pathophysiology of the underlying disease, signs and symptoms that we see in our patients, finally diagnosis, treatment, and management of our patients. So in terms of definition, what is adrenal crisis? Simply means a sudden defect in production of our adrenal hormones, specifically cortisol. And just like any type of regulation in our body, when it goes um, when it goes into dysregulation, such as our chemical or our hormone levels, it causes a lot of dysfunction throughout our body, and that can lead to potential life-threatening conditions. The next slide talks about the anatomy. So adrenal glands are simply little glands that are located on your kidneys. So you have one on the right, one on the left, and they are part of what we call the endocrine system. And so specifically, the part of the adrenal gland that produces cortisol is the cortex, or the outer portion. Okay. Cortisol itself has a lot of physiological effects when it's released into our body. It helps us maintain blood pressure. It actually increases our blood pressure. It helps cells get the much needed energy they need through the form of glucose. And these are the things that we need the most in time of stress. Next, we have a picture of the overall endocrine system and the big picture of how these things all work. In majority of the cases, is going to be a negative feedback system. So what that means is that as the body produces a lot of something, in return, your system is going to try to go ahead and decrease that level to prevent that particular hormone from uh, overtaking or growing exponentially in your body. So a good analogy would be kind of driving a car. You want to go ahead and accelerate to a certain point, and then you want to apply the brakes. Same thing with the adrenal gland is controlled by the pituitary gland, which is in return um, controlled by the hypothalamus. Next slide, we have here it is. Next slide, we have a diagram of all the different hormones that actually control the adrenal gland. First, you have the hypothalamus and CRH, which is corticotropin releasing hormone, and that gets related on to your pituitary gland, which releases adrenal cortex trophic hormone, and that is the signal to adrenal gland in order to release cortisol. So, pathophysiology. What is wrong in cases where we're having these adrenal crises? Well, as you guys can imagine, because the adrenal is responsible for producing cortisol, the adrenal gland doesn't work. So the question is, how come it doesn't work? Well, one of the prime reasons why it doesn't work is through Addison's disease, or this progressive disease, in which your adrenal gland slowly will decay or slowly becomes malfunction. A lot of times, the underlying mechanism of how that happens is an autoimmune entity. That means your body has these uh, white blood cells that really attacks any type of foreign enemy of your body. However, in autoimmune, instead of attacking foreign enemies, it attacks your own body. So as your immune system starts fighting against your own body, as you could imagine over time, that part that's being attacked gets weaker, weaker, weaker until it dies. So that's the case with Addison's disease. And one famous person who actually had this is our former president, John F. Kennedy. Um, so next thing we want to talk about are the factors that could affect your adrenals. Um, it could be lifestyle factors such as your emotions, such as mental well-being, coping with stress. It could also be some kind of chemical. So whether it's tobacco, whether it's alcohol, whether it's lack of sleep, um, caffeine, could all contribute to the function of adrenals. So in terms of our patients, what are we going to see when they have some kind of adrenal crises? Well, nausea and vomiting is very common. They're going to have dehydration, lightheadedness, syncope, weakness, fatigue, tachycardia. And one thing that they exhibit, which they don't, which other entities that we discussed in the past, is absent from, it's going to be abdominal pain. So abdominal pain is going to be a sign that's very, very common um, in adrenal crises, but not so much for the other issues that we talked about in the past. So once we know the signs and symptoms, how do we definitively know that that particular patient is suffering from the adrenal crises? Um, so in order to achieve the definitive diagnosis, we need blood work. And in the blood work, we're looking for not only your blood chemistry, whether it's going to be sodium, potassium, or your um, glucose. We're also going to be looking for cortisol levels as well as your HCTH stimulation test, which test the ability of your adrenal gland to produce cortisol. So what that particular test does, it has a tetra uh, cositide, and that's a synthetic ACTH, or the same hormone, um, similar hormone as your pituitary gland. It's supposed to stimulate your adrenal to produce cortisol. Now, if it doesn't produce the cortisol, adequate amount of cortisol, we can definitively diagnose the patient as some kind of adrenal insufficiency. Okay. Now, in terms of the treatment in the acute setting, what we'll be doing with EMS medical colleagues is going to be administering some kind of synthetic cortisol for our patient. And in this case, it will be hydrocortisone. Also, we have to think about in terms of their fluid status. So a lot of times we are going to be adding some fluids into them along with some glucose because we are anticipating them to be hypoglycemic because they don't have the stress hormones to increase glucose in their body. In terms of overall management, so once our particular patient leaves outside of the dental setting, goes to the hospital, what can we expect? Well, number one, we could expect that the hospital is going to be replenishing any type or correcting any type of electrolyte deficiencies our patients may have. So that means we're going to be having more sodium given to the patient. We're going to be having more glucose given to the patient. And also we're going to be monitoring the hyperkalemia or increase in potassium. So they're going to be on some kind of cardiac monitor because the most severe complication with hyperkalemia is going to be cardiac arrhythmias. Also, because you don't have adequate amount of stress hormones, the immune system is going to be compromised. So often they'll go ahead and add some kind of antibiotics as well. Once they get the patient stabilized, they're going to introduce oral steroids or glucocorticoids for patient to manage their cortisol levels long term. All right, so that's the background, and right now we're going to be moving on to the fun part, which is the case scenario. So this is something that could potentially happen in our dental office, and we want to walk through on our appropriate response in order to coordinate the care of our patient. So this is a 22-year-old female presents for sick health for right TMJ pain and inability to open her mouth. She reports tremendous fear of the dentist. During the examination, the provider palpates her temporomandibular joint muscles of mastication, and she screams in pain. She reports feeling dizzy, um, weakness, and fatigue. And the question for you guys is, how would you guys respond to her kind of complaints or symptoms at this particular point? You guys can go ahead and pause the video if you guys want to think about that, have your own list, and then come right back and we'll kind of discuss it. So in terms of management at this particular point, now we know something is wrong, so it's a good idea to get another set of vitals, whether that is something that we could get through a blood pressure cuff, or we could try to retrieve our ProPack in order to get continuous vital monitoring. Either way will be fine. Having oxygen on board in terms of supplemental oxygen, which is provided in every single dental room, would be a good idea. Also, thinking about the position of the particular patient, if you could lean her back, put her in the Trendelenburg position, that would allow her to be a little bit more comfortable at this point. Looking more holistically, I think it's important to kind of review her medical history, whether that means taking another look into her chart, or we could be asking her about, recent weight loss, any type of loss of appetite, GI symptoms, nausea, vomiting. Ask her about whether she had any type of postural hypotension in the past. Um, See if she had any type of bronzing or darkening of the skin. That would also be kind of signs and symptoms that we expect with undiagnosed Addison disease. Moving on to the next slide. So the patient says she has been losing weight over the last month from lack of appetite and fatigue. Her vitals that we got are 88/42. Her heart rate is 152, and her oxygen SpO2 is going to be 94%. Her temperature is 100.1 Fahrenheit. What are your concerns? What are your differential diagnoses? Again, if you guys want, you go ahead and pause the video right here, think about that, and come right back and we'll discuss it together. So at this particular point, the most important thing that we need to recognize is that her cardiovascular system is compromised. She has tachycardia, she has hypotension. And at this particular point, our differential diagnosis is pretty broad. We're thinking about, hey, she hasn't been eating well. She has a loss of appetite, maybe having some nausea, vomiting, some GI problems. So it could very well be some type of dehydration, hypovolemia case, right? She's tachycardic at that particular point. If we don't have a ProPack hooked up, so we really don't know any type of EKGs, it might be a good idea to do that now, because she could have symptomatic SVT, symptomatic VTAC. We really want to know what her rhythm looks like. Another thing that we could potentially be in this would be hypoglycemia. So that will explain a lot of kind of the symptom that she experiences now, especially with the syncope, especially with the lightheadedness and the weakness. Okay. All right. So moving on. Now our patient reports that she's very dehydrated. She has abdominal pain, and she starts to speak incomprehensibly. She faints and falls over. What are we going to do now? So at this point, it's really important that we stay focused. And just like any other patient that kind of faints, before we start BLS, or the first part of BLS is establishing, is our patient breathing? Do they have a heart rate? And are they able to respond to us? Now, if they can't do any of those three things, we want to go ahead and start CPR ASAP. And also, we want to go ahead and alert everybody else in the office that we need some help. Just like all our other patients, we want to help them in a very organized and team approach. So remember, we need to establish a team leader. We want to make sure somebody's doing compressions. We want to make sure somebody's taking care of the airway. We want to make sure somebody's retrieving the AED or applying the AED pads. And finally, we want to have a recorder to detail the treatments that we rendered, when the patient actually went down, in order to relay those particular items on our EMS or our hospital report. If we're in the clinic right now, I will be asking you guys way more in terms of demonstration of how to do chest compressions. What is the rate? What is the depth? In terms of breathing, how many breaths you get per minute for one rescuer, two rescuer, um, and also our adjunctive airways that we could think about. Um, moving in terms of this particular patient reviewing her dental records, there was a consultation made to the endocrinologist for Addison's disease. So kind of like what we expected with our probing questions, and also um, kind of helps us in figuring out where to go in terms of the treatment for her, because now we have that valuable information about increased chance of underlying Addison's disease. Now with the medical response team, assuming that you guys were leaving it, what would be your next step? And what other therapies would you initiate? So, in terms of medical response and treating her, the most important thing, like we talked about before, is going to be hydrocortisone. 100 milligrams IV, going to give that as soon as possible. We're also going to be starting um, some kind of fluid resuscitation. In her case, I know a lot of times we use D5 or LR, lactic ringer, or normal saline. In her case, D5, normal saline might be a little bit more appropriate just to get her glucose up, having some kind of supplement there. And that would be it. So the patient returns to ROSC. What will be the higher level management of the patient, and what type of testing would be completed there, and how is the diagnosis established? So once the patient gets transferred to the hospital via EMS, what they're going to do is go ahead and have the patient hooked up to cardiac monitors, make sure they get another set of labs to figure out what the electro, electric, electrolyte levels are at this particular point. Do they need to replenish sodium? Do they need to try to bring down potassium? Um, are they even at risk for hyperkalemia? And are they having any type of cardiac abnormalities? Also, at this point, they're going to be drawing labs in terms of diagnosis. They're going to be trying to figure out what the cortisol level is. They're going to try to figure out what HTA, the ACTH stimulating test, try to figure out if the adrenal gland is able to produce cortisol, um, and try to differentiate that between having low levels of ACTH or more of a pituitary um, problem. At this point, they're probably going to be ordering imaging, whether it's MRI, whether it's ultrasound, to actually visualize the adrenal glands on top of the kidneys, like we talked about.